And I think we're ready to start, Evelyn, if you want to kick us off.
Super, that sounds great. It's great to see some new and returning faces online with us today. We're excited with this next round of All Under One Roof, coordinating care for immigrant children with medical complexity today. This session is being recorded and we'll share it with you afterwards. Just a reminder, your microphones are muted, but we're a small and mighty group today, so please do unmute yourself as you have questions, or feel free to type those into the chat. We appreciate you keeping your cameras on. We really would like to build that community of learning, and that helps us get to know everybody when it's feasible. Also, just realize it's a-okay to be eating lunch. We really want people to be able to join and be able to work this into your busy days. Your completion certificates will be emailed. That's why it's important that you do sign on with your first and last names so we can identify you. Please rename by using the 3 dots on your Zoom screen if your full name isn't visible. So with no further ado, let's get started. I'm excited to introduce our expert panel. First, we have Dr. Timothy Ryan Smith. And
Hi,
Go ahead, Dr. Smith.
I am a general pediatrician at KU, medical director of our medical complexity clinic called Pillars at KU.
Super, and then we also have Dr. Emily Goodwin.
Hi, everyone, and welcome. My name is Emily Goodwin. I'm a pediatrician at Children's Mercy in the Beacon program, which is a medical home for children with medical complexity.
Super, and we're fortunate also to have Dr. Dana Bakula.
Hi, everyone. Nice to meet you. I'm a psychology fellow at Children's Mercy and work across multiple clinics with children with medical complexity. Nice to have all of you here.
Super. Well, with no further ado, let's get rolling and keep those questions coming to you.
So we'll start out with just providing some disclosures and some perfunctory housekeeping associated with the program. This session will be largely split into presentation, PowerPoint presentation on immigrant health, and then group discussion around the case. We kind of hope to get these balanced 50-50, but there may be a little bit more in the didactic portion of this session than the case. So next slide. No one on the team has any commercial or other disclosures to make. We do not plan on discussing at this session any unapproved use of a commercial product or devices. Next slide. The recommendations within this presentation are based on the best of possible evidence, but still should make the disclaimer that this isn't necessarily making clear determinations for specific clinical or other clinical cases or situations. Next slide. As soon as possible, the slides and recording will be sent to attendees. Dr. Nelson talked about the certificates of attendance. We do have a pre-assessment survey that we would like everyone to complete, and there'll be some feedback opportunities via survey after these sessions. But if you have specific questions also that need to be answered promptly, please email the telehealthrocks@kumc.edu email. Next slide. So the theme that is weaving together all the sessions on this group of teleconferences, this is our second session on managing care in children with medical complexity. But the common theme that we are going to address in these sessions are social determinants of health. And I understand that this is kind of verbiage that came out of the healthcare setting. But I think that a lot of the attendees from educational settings, policy settings are familiar with this terminology. So I want to get a sense, just starting out, what comes to mind when people think of the social determinants of health. And you can see some of the instructions for contributing to the word cloud below. And we'll give like 60 to 90 seconds to look at everything to give people a chance to answer.
I think you guys are familiar with this, but if you just click on the link that's in the chat, that'll take you there.
And I think I've seen some responses into the chat. We could also, Chrissy, are you able to input those for those that put responses in the chat? Or does it work best for people to put it into a link?
Yeah, if Emily or Dana could type those in, that would be wonderful. But we are seeing some come in, so it will change and grow as people are responding. And the words that are in bold are bigger, means that people have put them in several times. So we're seeing those words repeated.
Great, and I understand that we'll be able to share this word cloud as part of the slides once we're complete with the session. Let's give another 10 seconds for people responding. I still see all the responses sliding around. Okay, so I am not surprised, especially being in a group of educational professionals to have education highlighted, but there is certain that education for the people we take care of, the children we take care of their parents, is a very critical social determinant of health, and it touches other social determinants like health literacy, functional literacy. So I think that's really important. I think whether it's income, which is highlighted, or socioeconomic, again, the financial and other resources that families bring to our communities has a big impact on their health. I'm excited to see things like neighborhood and understanding. We have this community within our home, within our neighborhood, within our greater city and metro and state. So I'm excited to see that included. I see parents, definitely want to call out, we're all working together here, and it's important to understand all the different team members that we have. We did see, and wide ranging, I think just descriptions of, it covers a lot when we talk about social determinants, and we will certainly just have a like kind of right off the top review of those type things. So I think this is great, and I hopefully this is a helpful exercise. If we go on to the next one, this may have some overlap from what we had in the last word cloud, but maybe we'll get some slightly different answers, and we'll probably give a little less time, like 60 seconds or so, to respond to this one. But there's a whole concept of social determinants, but then like within your role, within your organization, which social determinant is most relevant, what you develop. And I see class that I don't think I called up class. It's kind of related to socioeconomics, but in other ways it's pretty distinct. But that is certainly something that we need to pay very close attention to, and is very relevant in social determinants of health. Accessibility, absolutely. Again, this parent-child, dyad, triad, if you will. Resources, so as we identify these as social determinants, what do we do about it? What resources can we bring to bear to navigate these concerns? Access, whether it's access to educational services, healthcare services, community-based organizations, that access is a broad and very important point, and kind of touches that higher line highlights of resources. Culture seems to be gaining some steam. We'll touch on specifically cultural competency and cultural considerations for working with immigrant children and immigrant families. Health insurance status, very, very critical. Whether you work in health or not, it is pretty clear that those that don't have health insurance have issues with healthcare access. Again, one of those kind of critical social determinants. And calling out things like religion. I think we called out gender in the last presentation, but these protected classes are important to realize that they do have a big impact on our social determinants. When we think about resources, things like proximity is certainly important. We need to get the resources, and we need to get resources that are really conveniently, appropriately available to the individuals that we take care of. So yeah, I think that's great. I'm kind of interested in moving along with the presentation. I think we'll close that. I think these are incredibly insightful and valuable responses, but probably to little one's surprise, our health and well-being is composed of a lot more than the healthcare services that we receive. And so again, there's all these different representations from different organizations to present health outside of healthcare services, but I think the general consensus is that healthcare is a relatively small part of what health is. And so understanding our environment, our socioeconomic status, our behavior is recognized as more and more important to health. And I think it's very positive because we as healthcare providers, as education professionals, as policy advocates are understanding if we're going to keep people healthy, we need to do a lot more than just focus on healthcare, but focus on these other social determinants and provide resources and services related to them. So next slide, please. Here are some of the different social determinants in kind of a list type form. I think this is a good kind of categorization. It's not exhaustive, but I think it's a good appropriate representation of some social determinants that we navigate. We'll focus on different social determinants over the course of these programs. I will pay particular attention today to a language, provider linguistic and cultural competency, and some of the other ones we'll touch at the presentation. But I think it's also important to call out, so we have all these different things that go together as social determinants, as all those things that make up someone's health. And then the different ways that we look at what is health, like is it life expectancy and mortality? Is it morbidity, quality of life? So there's all these different measures to look at, to pay attention to, and we're looking at social determinants and its impact. So next slide. Again, like these are things that are probably not shocking to a good number of the attendees of this session. Where you are and who you are really makes an impact on your health status, your health outcomes. The left slide, the left image is life expectancy within Wyandotte County. For those that are not familiar with Wyandotte County, the eastern part of the county is relatively less affluent, a higher percentage of immigrants, limited English proficiency families. And you can see pretty marked less life expectancies to the tune of about 10 to 15 years than what we see in the Western, more affluent, more suburban communities within Wyandotte County. So just physically where you are has an impact for how healthy you end up being. And I think it's also important to realize that even when we think about specific health conditions, who you are, what race and ethnicity you are, has an impact on your health outcomes. So this image on the right looks at years of life lost for different ethnic groups with diabetes. So, and the higher bars represents more risk, more poor outcomes than a lower bar. And you can see that non-Hispanic African Americans and non-Hispanic American Indians that have diabetes have much worse health outcomes, more life lost with the same condition than non-Hispanic whites and Asian Pacific Islanders. Next slide. So I wanted to highlight a few different social determinants as we kind of move forward to talking about immigrant health. I think that first one is adverse childhood experiences. I think in educational and policy realms, they've had a lot more experience with adverse childhood experiences than we have traditionally in the healthcare setting. We are starting to recognize it more and more. I think kind of one of the more popular topics across all of our different professional societies is trauma-informed care. And I think understanding adverse childhood experiences is kind of critical for framing that trauma. The slide on the right gives a kind of summary of some of the screening questions that are used for adverse childhood experiences, and kind of the greater categories: being a victim of abuse, neglect, household dysfunction, violence. All of those things come into counting as having adverse childhood experiences. And it's important to realize that these adverse childhood experiences have a big impact on physical and mental health. Outcomes are well known about anxiety, depression, but there's other mental health disorders like phobias that can be related. We see within our clinical practices, and we see this both in our nonverbal and verbal patients, those that have complexity, that may have impaired neurologic function, we see somatization. So as families feel stressed, there are physical symptoms that our patients are feeling, whether it's headaches, stomach pains, fatigue. There's real physical tolls that we see from adverse events. And I think it's also important to call out that by some studies, a majority of immigrants and majority of immigrants with children with medical complexity have clinically significant scores on adverse childhood experiences. So again, you can look at kind of that high risk ACE score, which is greater than 4 of these questions being endorsed. So it's really relevant to, I think, all of our communities, but specifically within our immigrant and medically complex immigrant communities. It's really particularly relevant. Next slide. Another thing that's important is immigration status. Over a quarter of US children are so-called children of immigrant families. That is, they are a member of a household that has one parent or a child that is foreign born. And it's important to realize that immigrants come from a number of different backgrounds and have a number of different stories. We'll kind of highlight refugees and asylees. There are a number of economic migrants. Some of these economic migrants that migrate to our communities for job opportunities may not have official immigration status and may be undocumented. Over the last 4 or 5 years, there's been a lot of attention to unaccompanied minors. So those young people that are under the age of 18 that don't have formal immigration status and don't have designated guardians within their communities that can take care of them. And then there are a number of different statuses in immigration, numerous different visa designations to allow professional workers to temporarily or permanently reside within the United States. I think of the J1 visa program that provides opportunities for a number of foreign-born medical professionals as one example of that. I think that especially amongst our undocumented community members, I think that we focus a lot on the obstacles and some of the challenges that are created by immigration status, but I think it's also important to realize the real strengths that we have in our immigrant communities. These multi-generation households that can share childcare duties, share healthcare responsibilities, can help navigate a complex system. So there's lots of strengths that we have, but certainly some challenged. And I think like at some point, this is a big debate within the section of child health, especially around the time that the issues around unaccompanied minors was gaining the most attention about 3 or 4 years ago is, do we screen, do we document for immigration status? It certainly makes a big impact on health outcomes, on wellness, but I think there's always been a concern that those things that end up in the medical record, that end up in educational documentation, can be used against some of our families, some of our children for deportation proceedings. I have generally included this information in my clinical notes, but done it very carefully. But you can kind of think about immigration status in 3 categories of either absent, temporary, or permanent. those with no formal immigration status or absent immigration status would be undocumented individuals. And so each of them, each of these categorizations have their special challenges. And just want to call out again, the specific program, which hasn't had a formalization into law, but is now just statute, is DACA, or Deferred Action on Childhood Arrivals. Next slide, please. And the last social determinant of health that I wanted to call out before we talk about some of the detailed components of immigrant health is language. I was somewhat surprised. I am having more experience throughout Kansas. I think these great sessions can connect people across our state. I see that we have some staff here from our Coffeyville public schools. I know Telehealth Rocks has had some strong partnerships with Southeast Kansas, but I at times can be kind of urban centric and Wyandotte centric. And I think if you look at the figure in the bottom right, it shows again that a significant amount of language diversity, specifically those with limited English, reside in communities outside of the urban areas of Wichita and Kansas City. And Robert had kind of talked about within Southwest Kansas, some of these diverse communities that exist. And so I think, again, like this is a challenge that we navigate, whether in the city, whether in the rural areas, whether in the exurban or suburban areas. Going back to that classification for children with of immigrant families, almost half of them have at least one member of limited English proficiency, and that causes challenge in the educational setting and the healthcare setting. That is best addressed with the use of formal interpretation. There is more studies going around as well as audio and video options for interpretation, and suggestion that video options, when those are available, provide improved care, improved outcomes to those of audio, but having those language resources available, trying to do everything we can to avoid using family members and putting them in the middle of technical and at times awkward conversations is really important. And I think it's important to realize that those with limited English proficiency have 3 times the risk of poor health outcomes for children with medical complexity than for those that do not. So next slide, please. So kind of thinking generally about immigrant health, immigrant educational attainment, providing high quality services to our immigrant families. There's a number of different things to consider. Certainly limited English proficiency. And I know within our practice, we have a broad number of services and tools available for Spanish-speaking patients, but not all. And we are definitely working as our health system to broadly provide services and resources in English and Spanish. But we also see people within our practice at KU upwards of 35 different languages. And so supporting not just our English-speaking patients or Spanish-speaking patients is critical to our mission. Health literacy is another thing that will come back in all of these sessions, and I believe Dr. Goodwin will pay some closer attention to it in her session. When we went back to the word cloud, income and socioeconomic status is a big determinant of social health, and we certainly see across our immigrant communities concerns for poverty. There is generally an increase with poverty within our immigrant populations. Kind of related to that is housing and food insecurity and the numerous different downstream health effects that has. We also will see just atypical infectious disease. Before I went to medical school, I was a refugee social worker and ended up bringing, I had about 15 refugees that I resettled one year, and 2 of them ended up being 2 of the 3 cases of malaria in the whole state of Kansas for that calendar year. So we do end up seeing less typical infections within these populations. We see a high degree of mental health disorders related to mental health within some immigrant communities, specifically within refugee populations. There is the presence of stigma around accessing care for mental health disorders, and one of those things that's really difficult to navigate. And whether it's medical complexity and developmental delays, neurologic impairment, other functional impairment, or things like malnutrition, our immigrant populations have significant risk profiles that we need to consider. And another thing to think about is whether or not some chronic health conditions are present on arrival or over time. Things like obesity, diabetes, a number of these so-called lifestyle conditions are adversely affecting our immigrant communities. Next slide, please. So upon arrival, there's a number of different things to consider in our immigrant patients. I will say that at the conclusion of our slides, we have our immigrant toolkit authored by the section on immigrant health from the National Academy of Pediatrics. And they have a lot more detail on medical screening, social emotional screening. And so I would encourage everyone to consult that resource, and I can't be exhaustive with all the contents of the resources in this talk, but one of those things, we're pediatricians, we're family doctors, we're always paying attention to vaccinations. Generally, the CDC recognizes documented foreign vaccinations. If those records aren't available, you can order serologies, but a lot of the times what we will end up doing is just revaccinating these patients if their records are not immediately available. We talked about, again, understanding ACEs, understanding histories of trauma, and so doing appropriate socio-emotional screening is really important. I kind of talked about things like chronic diseases like obesity and diabetes being present in these immigrant communities. Sometimes these conditions may not be present on arrival to the United States and may develop over time and be exacerbated by transportation issues, nutrition, food insecurity. All of these things may drive, and that's that so-called immigrant paradox, that immigrants may be more healthy upon arrival and then over time may have more concerns for common conditions. Again, paying attention to infectious diseases that are less common in the United States are really important. And again, like, can't stress enough this idea of coordination of care. Like, in the medically complex space, a good amount of our time and resources and multidisciplinary teams are dedicated to coordinating care and getting patients with transportation obstacles, lack of personal cars, unfamiliar with the bus system, to multiple different subspecialist appointments across a number of different institutions and clinical sites. Again, like going back to the word cloud, we talked about education. So getting educational attainment of our patients, as well as their functional status, and also functional status and educational attainment for parents is really critical as we get to know these families and we engage them in the medical home. So next slide, please. These are just a few of the screens that are established not just for Spanish speakers, but for a number of other ethnic and national groups. It's important when we do these social emotional screenings that they are validated broadly across different immigrant populations and in different languages. I know the Ages and Stages questionnaire is available in Somali and Khmer and Portuguese and a large number of languages representing a large number of groups. Next slide, please. So we have like those things to consider upon arrival. And then as we get established, specifically in the care of children with medical complexity, there's a huge amount of work when we have a child with cerebral palsy, with neurologic impairment, with severe autism, like getting them plugged into all the appropriate subspecialist therapies, educational setting is a big challenge. But then there is, of course, all the problems that occur along the life trajectory. And so over time, one of the things that we see is just generally immigrant patients, refugee patients, both with and without medical complexity, have lower utilization of care overall. They have less preventive care. They have and can have increased emergency room and acute care utilization. We certainly see a lot of oral health issues, and one of Dr. Law, who's a partner from Immigrant Health, who's going to help us with the case, Kelly Chrysler, has done some investigation into oral health needs in these communities. And I think one of those things that's really important, and it's not just over time, but whenever we take care of these patients, is as professionals that we have cultural humility, that we have sensitivity. I think again, it has been challenging and is always challenging to navigate the relationship between parent, child, and doctor with immigrant patients. Sometimes I've found that there's too much deference for just, well, this is what you say. And we really need to make sure that we are fully engaging and navigating difficult decisions with our parents and our families. So next slide, please. I'll kind of step aside from kind of these general things we think about with immigrants and talk specifically about refugees and asylees. So both ultimately gain status through a well-founded fear of persecution. Refugees obtain this status outside of the United States, and asylees will petition for a formal immigration status in the country that they're resettled to, or in our case, the US. So next slide, please. It is a long path. Many of the refugees I took care of when I was a refugee caseworker, we had a large number of Somali Bond 2 patients who had spent 10, 20, up to 30 and more years in Kenyan refugee camps. These can be in camps, they can be in urban areas. As a refugee, there are different things that can happen as you're displaced across a national border. You can end up going back to your country of origin. You can be integrated into the country that you were displaced into, or a large number of, the largest number of individuals that participate in our refugee and asylee programs in the United States, third country resettlement, where a family is designated as a refugee in a country of asylum and then relocated to a third country. So next slide, please. These are just some basic information on the U.S. refugee program. We have a broad number of different nationalities and ethnicities represented, and one that we're already starting to see a large number of arrivals from is Afghan refugees. Next slide, please. One of the things I think is important, and this isn't just refugees, but for immigrants in general, is you really can have novel perspectives on disease. I know when I was a refugee social worker, I was very struck by a presentation that KU medical students made to some of our refugees around tuberculosis. And they presented on tuberculosis, and one of the refugees, who was a college graduate and small business owner, had a very interesting question. And so as part of refugee screening, all refugees will get a chest x-ray, and upon arrival they get a TB, a tubercle skin test. And this person asked, like, so why was it that we left Africa and we didn't have a TB, but then we arrived in the United States and we did? And I think myself and my dad is a pulmonologist, were present at that conversation. I was really intrigued by the fact that, again, this whole concept of long-term germs kind of populating the body and causing these issues just wasn't something that I think everyone in this group of recently arrived refugees, new Americans, really truly understood. And so the table on the right is from the AAP policy on care of the immigrant child. And it's just some ways to engage our patients on culturally sensitive, culturally competent care, and how to understand how we understand disease, how we're treating disease, how we perceive disease. I know I have certainly had some, I had one family somewhat recently that had a child with a diagnosis of Down syndrome, and had some associated heart and hormone issues associated with their Down syndrome, and they very much internalized that background, that defect, as something that was brought upon them, that it was something that they did. And so we had numbers of different conversations. We involved pastors, we involved some other family members, some other community members, and kind of got ourselves to a different place. But again, what we know, what we expect, is not necessarily what our immigrant families know and expect. I think LEARN is a good acronym, getting familiar with that. And again, when we think about immigrant populations, it can be helpful to understand what's understood beliefs for different groups, whether it's those from Afghanistan or particular ethnicities from Burma, but realize that we can go to places like the U.S. Community Refugee site and look at these kind of descriptions on these groups, but each child is a little bit different, and so understanding that context too. Next slide, please. I'll try to move through this quickly. Information technology, it's becoming a greater part of our healthcare system. I do a third of my time with IT, so I would be remiss if I didn't include this somewhere in the presentation, but there is concern that those with limited English proficiency are using telehealth, are using patient portals, are using some of our technologies less. And that really creates a big rift in health outcomes and health access, when that's a way that a large number of our patient cohorts are accessing services. But there's some things, especially when we think about smartphone penetrance, using text messages and other tools may be incredible ways to get to refugees and other immigrants that we haven't been able to get to in the past. Next slide, please. These are a few of the resettlement agencies for specifically refugees and asylees. Next slide. These are some of the community partners with refugees and with broader immigrants. El Centro has been a leader for many, many decades in Wyandotte County, supporting Latinx community members. Next slide. Here are some of our resources, and I'll try to, we may send another email out with some other updates. I think that these resources may be a little bit slanted towards Northeast Kansas, but we'll try to get some broader resources across our state.